Moving to our next case, we're going to discuss a patient with AML with myelodysplasia-related changes, also called MRC. Dr. Riziri, could you please do the discussion?
Great. Thank you very much. I'm really excited you chose this case because this diagnosis is still somewhat confusing to me, so I'll be really interested in our pathologist's contribution here. But as you see in case 2, this is a 70-year-old gentleman with MDS diagnosed approximately a year and a half before presenting to our center with a very good performance status. The patient previously received azacitidine for 6 cycles and responded but did not achieve complete transfusion independence. The patient did experience mild depression and fatigue with therapy, but no other serious complications and no infections were noted. Past medical history was fairly non-contributory and only notable for hypercholesterolemia that was well controlled with lovastatin. White counts at presentation to us were notable for a white count of 1.9 with an ANC of 0.9, so mildly decreased, a hemoglobin of 9.2 with a hematocrit of 31. Platelets were markedly decreased, though, at 42,000 with peripheral blasts at 16%. A bone marrow aspirate biopsy were performed, and as we see, the blast percentage was 65%. Cytogenetics were returned indicating a del5Q and a del7Q, and molecular analysis was performed indicating that FLT3 was not mutated and a 75 gene panel was still pending at the time of evaluation. A diagnosis was made of AML with myelodysplastic-related changes, or AML-MRC.
Okay, well, thank you very much. So, Dr. Weinberg, we'll start with this patient now, getting the samples to you. And what would be the traditional workup in a patient that you did not know, for example, has MRC, and this is just a new AML? What would be the FISH probes you use, and what are the other nuances of the diagnosis?
So in all cases, we would look at the bone marrow aspirate and we look for dysplasia in the background cells. So taking aside the blasts, we would look at neutrophils and we would look at erythroid cells and we'd look at megakaryocytes and see if they're abnormal from what they normally look like. So in the setting of MDS, we would only need 10% of cells to be dysplastic to call it MDS. But in the setting of AML, we recognize that the body may be under stress and there might be a lot more dysplasia around. So we would require over 50% of the cells to be dysplastic. So if we see more than 50% of cells in each lineage, and we need 2 lineages to be affected, then we would say this case has morphological dysplasia, and then this is therefore AML with myelodysplasia-related changes. This is kind of a confusing entity because you can't see a lot of dysplasia in other types of AML, like therapy-related AML, or even AML with recurrent genetic abnormalities can sometimes have background dysplasia, especially things like 6-9 translocation. Or inversion of chromosome 3 or 3Q can have a lot of dysplasia in the background. So if you see morphological dysplasia, that would lead us to AML-MRC. Or if cytogenetics comes back and instead of a normal karyotype, we have abnormalities of chromosome 5 or 7, or we have at least 3 or more unrelated cytogenetic abnormality, what we often refer to as complex karyotype, that's what we would consider as AML-MRC. The third way to get into this category is to have a history of a previous myeloid neoplasm like MDS or a mixed MDS-MPN. That would also qualify somebody as having AML with myelodysplasia-related changes. Of course, that could be a little confusing because you could say, why is this not therapy-related AML if they had therapy? And some of these nuances, I think, are just hard clinically to sort out. But we would do the same thing that we would usually do. We would do cytogenetic analysis, which you grow the cells and you look to see any abnormalities. The problem with FISH probes is that you have limited probes. Most lab will do probes to chromosome 5, 7, or 20q, and maybe chromosome 11. But a cytogenetic analysis really lets us see the entire range of abnormalities that may be present. The problems with cytogenetic analysis is that it may not grow, especially if it's being sent out to a reference laboratory. It may fail. For maybe other sort of reasons, so that's where FISH can still be really helpful. And then there's been some reports where, which show that some abnormalities that we see on mutational panel may indicate an underlying MDS. So if we see things like P53 mutations, or we see SRSF2 or SF3B1 mutations, that may indicate that even if there's no history of MDS, there may be an underlying MDS that was not recognized because maybe the patient just didn't present for a long time to a clinician, or maybe transferred hospitals and we didn't have a good story of what happened.
So go into the mutation and how they, because I think this is something that's emerging, especially in the HemePath publications. So are there any mutations that clearly rule you in or out from MRC? Like you mentioned, maybe the TP53SF3B1 could be suggestive, and then there's some data with NPM1. So how do you look at, let's say somebody has not enough dysplasia to meet the 50%, and then you see some of these mutations, which ones can really say this person should be MRC or not?
Well, I think that kind of remains a subject of the study. I don't know that it's very definitive. And there's been a publication out of Dana-Farber by Coleman Lindsley that addressed it. I don't know actually of any other publications that looked at it. But in that study, they found that things like NPM1 mutations were more likely to be associated with de novo AML. But we've all seen in clinical practice NPM1 mutated AML that arises after MDS, or core binding factors, leukemias may have that. Outside of that, there's certain mutations that may underlie secondary MDS, like SRSF2, but none of these are very specific,
right?
or definitive. I would say the most definitive things are morphologic dysplasia and cytogenetic abnormality, especially complex karyotype or abnormalities of chromosome 5 or 7.
Yeah. So that's useful. So at this time, I think, so the three groups we could think of are people who have known secondary ML, known chemoradiation, and then known cytogenetics. The molecular is still in process. We're not sure if we can use that to differentiate people.